competencies are required of this person. That means, what are the limits of competency and authority? This person will be delegated to perform certain responsibilities and certain job. It should not happen that the home health aide will do any work in the home setting. It is not that he is like another helping aid in the home. He's a professional. That mindset need to be created not only among the users but also among the employers. What exactly he is going to do? That is taught through our national occupation standards. So if I just go into a brief job description of home health aide, so he's the person who provides routine individualized care to elderly, not only elderly, it's convalescent patient who are it's bedridden patient who are comatose, patient who need prolonged care at the home. They are competent to monitor or report changes in health status and assist to cope up with their rehabilitation and the well-being. And it is all integrated with the technology. So in the cities, we can find that there are providers. But if we look into the downer level where, B cities or C cities, so there are people who really require these. So connecting them through telehealth. So we are training our, home health aides to work how to, channelize through a telehealth so that healthcare facility can move into those directions as well. As the time up, so I just want to click on a very important point. So if you refer to National Health Policy 2017, which has recently come up, so in the National Health Policy also, policy says a special focus and emphasis on geriatric care. Now, and among home health care, there are different, other profiles as well. Geriatric care is one of them. Infant care is one of them. Then maternity care is one of them. So different domains are coming up. Means different job roles, different opportunities are coming up. So Sector Skill Council have again created a draft standards. Third important point, then the Sector Skill Council is mapping our standards with the counterparts. For example, if we look into the UK system, they also have their social caregiver or the home health caregiver. Australia also have. So mapping is done so that we can provide our skilled manpower trained on the gaps to move on to the other countries. Yeah. So thank you so much. It was really nice to interact with you all. Thanks for your patience listening me. Have any question, feel free to take it out after the complete session. Sir, we can have it after the session. Thank you so much.
Thank you, Anshu. May I request Dr. Anuradha? Dr. Mahesh Joshi would be after that. PPT?
Good afternoon, everyone. I'm very pleased to be a part of this panel discussion on home healthcare industry in India. Though it's a very established industry, very much a part of the healthcare ecosystem worth billions of dollars in the Western world, in India, it is still a very nascent industry. And as with any industry taking baby steps, there are a lot of challenges in the industry like Dr. Mankad mentioned. And I'm going to put these challenges together for the panel to discuss further. I think we are all very excited about the projections of the market value. I'm having the same industry projections as Dr. Mankad. So currently it is valued anything between $2 to $4 billion in India. And it is projected to be $6.21 billion in the year 2020. This is roughly about 2% of the 160 billion healthcare industry in India. If you compare that with US, which is around 9 to 10%, the home healthcare industry is about 9 to 10% of their entire healthcare industry. So I think there is a lot of potential here if we can address the challenges. So I've just put a few quick points as to the key benefits of home healthcare. One is convenience. Basically, we want everything at home nowadays. You talk about shopping, beauty services, you name it, you can have it. I think, healthcare also is finding acceptability for having it at home right now. But it has some great advantages if we address it in the proper way. For example, I put the lower chances of infection. In India, it's a very major concern for all the industry players for hospital-acquired infections. We seem to have acquired a very infamous fame for harboring the most virulent organisms in the world for hospital-acquired infections. So if we adopt home healthcare practices, keeping the hospital stay to an optimum level. I'm not saying, like Dr. Mankad said, that we should replace home health care, or we should replace the hospital healthcare with home healthcare. That's not going to happen. So if we can keep the hospital stay to an optimum level, then we can reduce the infections, the hospital-acquired infections, to a great extent, and significant cost savings. There are a lot of research papers which detail out the amount of cost savings, and most of them are in the Western world, because, as I said, this is a baby industry and it saves time and effort. You go to a hospital or you plan to take somebody from your family, it's going to take at least half a day. Even if your appointment is just for half an hour, your traffic, parking, hassles, and so much. So I think, having home healthcare, it does save time and efforts. Obviously, it is a very personalized healthcare because it's a one-to-one care provided at home. So some of the challenges I have mentioned here, the first thing we face is a perception barrier. Like Dr. Mankad said, the challenges here starts from there. Because, they are not able to differentiate between a care provider and a maid service. We have had many, many instances where our nurse has been asked that, "Kali baithe ho, baal mein tel laga do," or, shoe polish kar do. Upar se terrace se kapda leke aa jao. The caregiver, I always tell my staff that caregiver has to have a different mindset. The work atmosphere I come from, I worked in England for 10 years. The caregivers are given the utmost dignity. I mean, not putting it in a very bad light. We have also had instances where I was really touched. We had a judge of one of the high courts, and he was really ill. He was at the end of his life. Our staff was providing continuous care, and his daughter said to me that, give him leave on Diwali day, because wo man mein gut ke, if he touches my father, the healing touch won't be there. So there are, various perceptions, but most of the time we face challenges here. That is again related to your low margins leading to scaling difficulties. So when we charge, or when we say 600 rupees for post-cabbage dressing, after a major operation, if we are going to send somebody for a dressing and you quote a price of, say, 600 rupees. Oh, ye to bahut zyada hai. So where are we? I mean, there is a trained professional who is going, and your logistics and the time and everything is involved. And I call a cleaner in my office. He charges 400 rupees per hour. So, I mean, the perception here that the caregiver is somebody who is a trained, qualified person who is coming with a highly skilled atmosphere is not being perceived at all. Okay. So when I say low employee utilization, rising wage bill, lower margins leading to scaling difficulties, all that to some extent related to the perception barrier. We don't mind spending, if you go to a beauty parlor, all the ladies here will vouch for me, that if you go to a beauty parlor, your minimum bill is 2,500 rupees. Pedicure 800 rupees, your hair cutting is 1,500. But if a doctor comes home, you charge 2,500 rupees. I have had really funny responses. So the perception barrier, if we can establish that the caregiver or caregiving atmosphere needs to be different. It cannot be replaced by your maid services. I think we have crossed the hurdle there. And then the second point is lack of quality on-call staff to reduce operating costs. First of all, there is a very huge shortage of nurses. And then, most of them look down on home healthcare as a career option. Whereas in, Western countries, there is, it's a separate career option, and there is standardization and everything, even for nurses. I'm not even talking about nursing assistants. We have community matrons, we have nurse practitioners, we have nurses. When I come to the nursing assistants, we have hired trained assistants from one of the deprived states, I must say. They don't know, if you tell them move the curtains, they don't know what is a curtain. How are we going to send them abroad? I don't know. Sorry? That's my question. You don't need to send them abroad, or if they are not fitting in the atmosphere in our own metros, how are they going to manage in? Sorry? We are having shortage in our own country, but the government has this, program in which they want to send people abroad, but they are not ready yet, because they have not been given the kind of exposure. Maybe they have got trained, but they have not been given the kind of exposure. I would prefer them to work. Sorry? That's right. And they can have experience. They can always go abroad. Let them have it as a career option. Let them have it as a career progression. Let them work here, and then they can go abroad. Doctor, you want to say something? So, and then logistics issues. Our cities are expanding like baskets, around all four sides. And, it plays a very major role in logistics. If a nurses are, living in one area, say, for example, you have a hostel and you have an emergency demand 1.5 hours away, or how do we move them? So there is a great logistics issues in home healthcare industry. Technology challenges. Connectivity is a very big issue. We have created all apps, and real-time data can be accessed and everything. Not yet fully successful. I think technology people are here. Wearables are a great way of removing the manual interface and providing care through remote monitoring. But it has to be supported by the infrastructure. And lack of full insurance cover and legal liabilities. I have 2 separate slides for that. So, how to address the insurance challenges? It's a great way. If the insurance can cover our home healthcare industry, it's going to give a very big lift for this industry on the whole. But it is not even in their far side. So when I interact with the insurance agencies, they ask me that even for hospitals, we do not have standardized procedure or a claims. For example, for a cabbage, one hospital and the other hospital, they don't share the data. So they are not able to have a peer review report. This is in the established industry. So where is the standardization for home healthcare industry? So they are not even looking at covering it in the near future. What they cover is this, that if illness, disease or injury in which the normal course will require a care at hospital, that means a hospital has to refer them that this is the continuity of care from hospital to home. Then they cover it, and the expenses incurred before or after hospitalization for treatment of diseases. So there are lots of ifs and buts there. 2 weeks they cover. Thank you. I think my time is up. So if the insurance industry can cover it, it's a win-win for all. Better care, improved outcomes, reduced claims cost even for them, and newer care models can develop. And then this is the last but not the least, the regulatory challenges. Though there is a professional indemnity for all the professionals, which is an insurance cover to cover liability falling on them for errors and omissions committed while discharging their professional service. So who can avail indemnity? Doctors and medical establishments. As a home care company, I can avail liability cover for my staff, but it cannot cover a freelancing person who can work with me, the on-call demand staff. So all the big funds, if you talk, they are all interested in funding establishments who are working on the aggregator model. What they don't realize is that we are not as a foreign country like America. The cares are standard, qualities are standard, so you can have an on-call staff. Whereas here in India, the professional indemnity does not cover the individual professional. So how do you cover the just 2 minutes. How do you cover the operational efficiency and your profitability with the legalities? So they should cover, I believe, individual indemnity cover should be provided. So we should focus on, can I have just 2 minutes? Okay. So we should focus on covering higher value care, whereas, the diabetes care, oncology care, these kind of things cannot be covered by maids. So, as establishments, we should focus on higher value care and seamless care experience. Our healthcare ecosystem is so fragmented. I come from a paperless atmosphere, and here it's just, very frustrating. Your doctors work in a different tandem, and your insurance details are not provided, your care details are not provided. Our, okay. Okay, our. True. And then the standardization of care quality across the country has to happen. It has to be supported by technology, both in terms of wearables and point of care diagnostics. And we need to have really trained quality professionals. Now, I'd conclude with that. We cannot accomplish continuous care processes without working together. And these are all the stakeholders. Thank you so much.
Thank you, Dr. Anuradha. May I now request Dr. Joshi, please? He's from Apollo Home Care. Request to stick to time.
So let me understand what is my time.
12 minutes.
12 minutes. I'm glad these guys are not with IPL. If they were in IPL, the first 10 overs would be 6 balls, the next 5 overs would be 5 balls, and the last 5 overs would be 3 balls. It will still be a 20-over match. I think what I'm going to share is the experience of last 3.5 years. I was a clinician practicing emergency medicine, and I'm actually very nostalgic when I stand here. 10 years ago, I was talking something about challenges of establishing emergency medicine in India in symbiosis. And we are still establishing emergency medicine. So this journey is going to be long, but I think it's good that we have started looking at it. And I must appreciate, again, as Dr. Manka said, that I'm glad that home health care is featured as the pre-conference in the pre-conference workshop. That's just about 45 seconds, okay? So I'm going to quickly focus on challenges. I see you heard a lot of things. I just took some management lessons and tried to bucket them. You like this word, right? Management students, let's bucket it. So that's what I did. So if I look at from the ground experience, what I think are challenges, this is what you can bucket them under. There are large operational challenges. First and foremost of that is the logistics. How do you, for one service, right from age, good looking, bad looking, Hindi speaking, Marathi speaking, Telugu speaking, Tamil speaking, very skilled, unskilled, adjusting in Hindi household, all kinds of things are there to select the manpower. So there are a lot of operational issues. And this is where the efficiency of any company will come into play. If you look at, I've highlighted 2 important things in this red here. First and foremost is HR. Getting people, training people, retaining people, biggest challenge. Close to 100% attrition. On a monthly basis, about 8 to 10. I hate the first 2 days of every month. Because the third day, usually I see that some of my best nurses have gone for just about 1,000 rupees more from a competing company. That's the threshold of people that they move in. So it's a huge challenge. Risk. I think a couple of speakers already talked about it. There's a huge risk in this business. We are being beaten up in the hospitals. You imagine now you're there standing in the home. Right? So I just read something today that the AIMS doctors are getting self-defense classes, something. I just actually got a WhatsApp of a paper clippings. So I think home health care should additionally have highly skilled martial arts as a qualification into that area. Okay, legal, huge gray area, and that's why that block is in gray. Just like what it happened, paramedics, what it should be, can they give adrenaline or not, can they resuscitate or not, who is accountable if a death happens. These are still gray in emergency care. I'm sure a lot of you did your life supporter courses from Pune, etc. And whether it should be Ayurvedic doctor, a homeopathic doctor, or an allopathic doctor, still a gray area. Despite now we have a DNB in emergency medicine, we have an MD in emergency medicine. These challenges will continue because we don't like to solve problems, we like to talk about problems. Okay. Then we come financial, the payer and payee. These are two big challenges. Who is paying for it? You know, we're looking at the world standards, but we're forgetting that the insurance is paying there. Here it's an out-of-pocket spend. So it's a very different world in terms of doing home healthcare here. You cannot just extrapolate US or UK thing into an Indian ecosystem and say it can be done in that manner. It's a completely different world. And if you feel that hospital business is difficult, just spend 3 months in home healthcare. You'll understand how challenging and difficult it is, all right? Academic and training. The cornerstone of any good home healthcare company is continuous training. How do you train and retain people when they are working 12 hours a day for 6 days a week? Impossible. Just impossible. And then the patient says, "Ye chehra bilkul change mat kijiye, doctor." If you change, they call your MD. If the MD doesn't listen, they'll call the chairman. And if they don't listen, they'll call the chief minister also. And I'm not joking. People become so obsessed about the care provider that they'll go to any extent. It doesn't matter. So that was about 2 more minutes. Okay, you're keeping a watch. Accreditation. This part was not highlighted as much. We did have about standards. So is there something to look up to? Do we really need to reinvent the wheel? I think there are good accreditation standards laid down. If you look at hospital standards, NABH was actually derived from Joint Commission standards. You don't need to do a lot of groundwork because Google Uncle is there. Copy, edit, paste and give it to people because those who frame the policy, it's not their problem. The problem is for people who are going to be implementing. And as Madam said, it's very important that home healthcare providers write this down because what is written there is a completely different world. $2,000, you get the complete package. It's all available. But you can't do in a 30% of that cannot be applied in Indian context. It has to be completely revamped for the Indian context. So if you look at something to look up to, you have the community health accreditation partners, you have the Joint Commission standards, you have the ACHC. There are various agencies. It's become a big business for them now to accredite the agencies. And we are aware about this going by the hospital accreditation thing also. But yes, for some standardization, accreditation has to come in. For a way to assess efficient, inefficient, good versus bad, at least there should be some benchmark. That's where it helps. All right? So current status is that we don't have any defined guidelines, standards, etc. There are no standard measures on what is a good home. The only thing good is if the patient feels good, then it's a good home health care company. All right? So it's not true because there are 2 broad areas of home health care and I want to highlight this. One is called as skilled home health care. The other one is non-skilled home health care. What is a home health aid or a GDA is largely focusing on the non-skilled part of it, which is a majority component of home health care. But the skilled is where you really need to have good standards and accreditation measures to actually look at what are the process measures, what are the outcome measures in terms of the interventions being done at home. Data, every company is coming with a new app. Where and how this data is going, who's monitoring, what is the security of it, there's a huge challenge there, all right? So who are the people who need to get involved? I think the home healthcare companies need to take lead, and I'm glad Nat Health as a forum has initiated this already. MCI, NABH, the hospitals, I think it's a sorry state that today home healthcare providers actually have to seek business from hospitals. It should be otherwise. The hospitals guys must be looking out for home healthcare. It just doesn't take much